the lecture to introduce his company to us so that students will also get some glimpse of what is possible with unlimited, I would say, opportunities they have in front of them. So he's an avid clinician as oral diagnosis and radiologist. He is also expert in medical education and many other, I would say, awards under his belt. So over to Dr. Sumant. We are already late by 5 minutes. He already has a meeting after 25 minutes. So I don't waste time. Welcome, Dr. Sumant. Over to
Yeah,
you.
thank you. I'm sharing my screen. Um, can you see the slides? Can you see my slides?
Yes, we can see your slides
Okay,
very well.
right. I'll just start the talk then if everybody are ready.
Yeah, we are ready. We are ready, eager to listen to you.
Okay. Yeah. Good afternoon, dear students and colleagues. So, as you have invited me to talk about this ectodermal dysplasia on the International Ectodermal Dysplasia Awareness Day, that is 20th February, I'm glad to be there with you virtually. And this is something I'm happy to share the experiences and the current knowledge about ectodermal dysplasia. As Dr. Niranjan has introduced, I'm working as a clinical lecturer in Peninsula Dental School, and I own a company, Evident Research Consultancy. Along with that, I'm working as an adjunct professor at Military Dental College, and also I'm a clinical editor for Open Health. Is it possible to mute the videos because I'm getting a lot of echo?
Yes, you're right. I think it's better that we close.
Yeah, perfect. Okay, what are ectodermal dysplasias? It's a group of inherited disorders involving defects of hair, nails, skin, teeth, and sweat glands. But actually, there are more than 50 subtypes that have been described, and they are commonly classified based on the presence or absence of sweat gland dysfunction and based on specific genetic defects. These genes, which are responsible for ectodermal dysplasias, they are involved in embryological signaling pathways that regulate the development of teeth, hair, and salivary glands. So broadly, ectodermal dysplasias have been classified as pure ectodermal dysplasias and complex ectodermal dysplasias. So what does it mean? Pure ectodermal dysplasia, only the derivatives of ectoderm are affected. So the classic examples are hypohidrotic ectodermal dysplasia and hidrotic ectodermal dysplasia. So hidrosis means sweating. Hypohidrotic means less sweating. Hidrotic means normal sweating. Coming to complex ectodermal dysplasia, other than the derivatives of ectoderm, the derivatives of endoderm, mesoderm are getting affected here along with the ectodermal derivatives. So it is known as complex ectodermal dysplasias. Some common examples are ankyloblepharon ectodermal defects with cleft lip and cleft palate syndrome. Here the bone is affected. As I mentioned, it's not only ectoderm, even the endoderm and mesoderm are getting affected. Similarly, ectrodactyly ectodermal dysplasia, clefting syndrome. So coming to the classic ectodermal dysplasia, we will see abnormal hair, as you can see in this picture, abnormal nails, and abnormal enamel. So what we call it as trichodysplasia, onchodysplasia, and enamel dysplasia. So, if you remember your embryology, human organs or human body is made up of three layers: outer ectoderm, inner endoderm, middle mesoderm. So, the outer ectoderm, that is what is affecting in this particular disease. Differential diagnosis for ectodermal dysplasia usually is similar disorders which are affecting the ectoderm, like ichthyosis or Witkopf syndrome. Coming to oral manifestations, which we are more concerned about, first one is the hypodontia, second one is the enamel dysplasia, followed by xerostomia and some of the morphological changes such as conical or peg-shaped teeth, microdontia, sometimes taurodontia, delayed eruption, undeveloped ridges, and malocclusion. Now, what are the factors influencing dental care in ectodermal dysplasia patients? First one, there are limited resources because only few dentists are familiar with this syndrome and there is uneven geographic distribution of this disease. So, not many dentists are trained to treat ectodermal dysplasias. The second issue is the socio-economic barriers. The patients with ED need extensive care, which is expensive, and many families in many countries there is no dental insurance or financial resources specifically allotted for such syndromes. And the next factor is cultural factors. There should be motivation, compliance, travel costs that is inherent for dental treatment, and childcare access. All these things impact the treatment. So basically, a comprehensive assessment of general health is necessary before planning any definitive dental treatment. And also, some of the ectodermal dysplasias have associated immune deficiencies leading to recurrent infections. So, I have divided the treatment guidelines into four groups based on the age of the patients, that is, preschool, school age, adolescents, and adults. However, treatment for ED persists throughout life. The prosthetic cleaning and maintenance are necessary always. And cleft lip, cleft palate cases, especially, they should seek multidisciplinary care teams rather than only handled by the dentists. So, first group, the preschool children, that is 0 to 6 years. In these cases, either the children may not have all the teeth erupted or some teeth erupted. But if the child has no erupted teeth by age 1, then the patient should be evaluated for ectodermal dysplasia. After age 3 or across age 3, if the teeth are missing, then removable dentures or overdentures can be planned. Dentures must be the size and age appropriate. It should be customized for each patient. Implants are definitely not recommended in this age group, and rigid fixed prostheses are not recommended because these may interfere with the growth of the patient. Coming to the second group, school age children, that is 7 to 12 years. Here, there is a possibility of transition from primary to secondary dentition. Therefore, we need to minimize the influence of prosthesis on facial growth and also enhance speech and aesthetics. So usually we plan removable dentures. Fixed prosthesis is rarely planned, but if it is planned, it has to be planned with caution. Implants can be given only after the age of 7, but only for the anterior mandible, not for any posterior mandible or maxilla. And bone grafts are not recommended in this age group. And wherever possible, try to retain the primary teeth because it preserves the alveolar bone for future implant planning. Coming to the third group, that is adolescents, 13 years till the skeletal maturity. Appearance is critical in this particular age because the child has entered the teenage. Poor self image has a negative social and educational effects. So, this is the age when the child starts getting worried about public bullying, the influence of peers. So, patients might seek active dental treatment in this stage. So here, rigid fixed processes can be given only if the growth of the jaws is complete. Implants in anterior mandible until the growth of the jaws are completed. Do not plan any other type of prosthesis in this age. And lastly, adult treat options. The goals in the adult treatment options are to restore complete function and optimize aesthetics. Here, fixed restorations are preferred. So you can see a comparison between a before treatment and after treatment in a patient where the dental treatment for the ED patient has successfully restored the aesthetics, confidence, and quality of life. In adults, we can plan implants anywhere in the dental arches, but majority of the times, because of the lack of alveolar bone, bone grafting will be necessary. However, treatment requires lifelong maintenance and probable revisions. Therefore, you need to select those implant system based on the evidence of strong clinical research and a reputable company support, because this is going to be a long duration treatment. Other than the dental problems, we'll also see multiple oral problems in these patients, such as xerostomia that leads to fissure tongue, angular cheilitis, and increased smooth surface caries risk. So, how do we handle that? Of course, we need to treat the carious teeth with the restorations. Plus, we have to think about the preventive methodology, that is, regular application of topical fluoride, high fluoride toothpaste such as Durafat 5000 ppm. Salivary substitutes. I have just shared one of the salivary substitutes that is marketed. So, any salivary substitutes can be given here. If this is not economical, we can advise the patient to do the frequent water sipping and sugar-free chewing gums to stimulate residual saliva flow, dietary counseling to reduce cariogenic exposure, and definitely a close recall intervals at least once in 3 months. So, in ED patients, another area which we need to think about is the general anesthesia risk. General anesthesia carries a lot of risk in these patients because of the impaired thermoregulation. These patients cannot control their body temperature, so there is a risk of hyperthermia, especially in children. That's a reason we have to really plan general anesthesia based dental treatments. And also, because of the xerostomia, there is respiratory and mucosal dryness that increases the susceptibility to infection. Plus, because of these dryness, airway challenges will be there, that is, risk to difficult intubation, mucosal trauma, and post-operative airway complications. And lastly, as I mentioned, there is immune dysfunction in these patients, so there is increased perioperative risk. I have summarized the age-specific treatment guidelines in this table based on the 4 groups of age what I just mentioned and all the possible dental treatments. So if you see the green tick, it is appropriate. If you see the red mark, it is not recommended. If you see the yellow mark, that means use with caution, or you have to take a decision case by case. And I have given the complete reference for this guideline here, which is published from USA. So you can always click this link for further details. Now, coming to insurance and other issues related to the dental treatment, oral manifestations are components of genetic medical disorders. So, costs should be covered by medical insurance ideally. If at all there are no insurance or so, if the country doesn't have insurance policies for dental treatment, then advocacies can help to cover the mandated coverage, and also the state can plan special budget for treating these patients. We always advise to seek a multidisciplinary team to manage ED patients because they would have got the training experience with managing EDs, and also they would have had specialists in implants, and also there is support from medical team. Timing of the treatment is definitely important because these are high risk patients. So, caries and xerostomia should be treated as early as possible, and sometimes lifelong periodic dental care is necessary. Beyond dentistry, medical collaboration is something mandatory in ED patients. For example, pediatrician is necessary in the treatment group to take care of the nutritional concerns and growth of the patient. speech and hearing, especially due to hypodontia, cleft palate, and mid-ear infections. Dermatologists to take care of the skin, hair, and nail abnormalities. Ophthalmologists to take care of the dry eyes, and ankyloblepharon. Ankyloblepharon means the union of the eyelids. And psychologist is most important because of the lack of self-esteem in these patients. Remember, these patients are highly prone for bullying, and that leads to a lot of psychological issues. It's not only children, even the adults are prone for bullying because of their appearance. That affects their psychological health, that affects the quality of life. So I have given two pictures here, before treatment and after treatment of a ED patient. Look at the confidence, look at the smile of this patient after the successful dental treatment. So this way we can definitely improve their quality of life. By transforming the smiles, we can transform their lives. So, coming to the summary of ED, I have put a picture of diverse ED patients from different corners of the world. So, this is definitely a global problem, but there are some areas, some countries with a high possibilities or high prevalence of ED. That is where we need to customize the teaching and the curriculum for dentists based on the prevalence of the disease. So, if you want to remember what was taught today, just remember ectodermal dysplasia affects all four T's. That means teeth, trichology, that means hair, tegument, which means skin, and temperature regulation. And dentist is usually the first clinician to suspect the condition. Early prosthodontics improves psychosocial development in these patients. You do not see many teeth in these patients, but you see a great deal of biology, how the genetics impairs the body growth and how it affects the overall well-being of this person. That is what we can learn from ectodermal dysplasia patients. So I'll just stop my presentation here. Are there any questions?
I have
Uh, Good afternoon, Suman. Dr. Suman, thank you very much for very informative presentation by you. I have my two questions, but I will post them, ask them at the end. We will ask the student community to ask a few questions to you. If you allow, I will ask them. This is the hot seat, so I will vacate my hot seat to ask the question.
Sure, sure.
I will come back for my question.
Yep.
Thank you. My name is Jimmy Confiance Suizo, and it's a pleasure with the presentation that you shared about the Ectodermal Dysplasia Day. We have seen it's a condition which is genetic, which happens in the society, and we are for this as for awareness. And I'm asking the question, how can parents know that their children have affected with this condition of ectodermal dysplasia? How can they know that it's ectodermal dysplasia? Which reference or how can you orient them to medication? Thank you.
Yeah, as I mentioned, this is a genetic disorder, Samuel. So, usually this is X linked. There will be some traits in the family. Either some of the members are already having this particular disease or they are carriers of this disease. So, basically, first thing, how strong is the family history? That is what the parent should be checking. If there is somebody in the family with the history of ectodermal dysplasia, that is something they need to think about whenever there is delayed milestones in the children. So first delayed milestone is the eruption of the teeth. As I mentioned in the slide, if none of the teeth have erupted even at the age of first year or completion of first year, then that is a red flag. Then, so for positive family history, lack of any teeth in the oral cavity at the age of first year should be warranting the patients to go for a complete checkup, and also counseling with a genetic specialist or a family physician to rule out ectodermal dysplasia. And third issue would be the hair growth. So majority of the AD patients, the hair growth will be minimal. Hair will be thin, it will be sparse. So at the end of first year, at least the child should have good amount of hair. But if it is not there, the teeth are not there, then there is a strong family history, then the probability of you seeing a ectodermal dysplasia is very high. So these are the three things that you should use as red flags to educate the parents.
All right, thank you. That's the best response concerning my question. One more question that I have is there are more rumors or myths concerning ectodermal dysplasia. And you, as a profession who has been in this career for long, I would like to ask how people with this condition should be, or how the society should treat them. Thank you.
Yeah, I have seen majority of the misconceptions about these disease. I have witnessed people, even the neighbors, avoiding meeting these children. Sometimes they are called a sort of cursed child, or even people have called them devil's child. So there is a lot of bullying that is there. These people are witnessing. So the bullying is the major concern for parents because they don't want their children to suffer. This needs a sort of socio-cultural interventions. So this is something what your university or a day like this, where we need to increase the public awareness about the ectodermal dysplasia by putting posters, giving some television advertisements, social media campaign, just telling them if the patient appears like this, it doesn't mean anything wrong. They are diseased. It is a type of disease. It is a type of genetic defect. So this needs to be understood by everyone so that they are not bullied, and it will help them to confidently face the society.
All right, thank you. I appreciate the responses. We, as the people who go in the community, we need to tell them about that they are people too, and they have the full rights and they need treatments.
Yep.
And I appreciate your response, and I will hand over to my colleagues if they have other questions. Thank you.
Yep. Thank you. Thank you, Sam.
Okay.
Okay, thank you, sir. Uh, we are very lucky to be honored to have you today. And I had a question which goes like this. It's not included into the presentation, but I wanted to ask so it can be better next year as we be preparing this awareness well the whole month of February. So we wanted to create a association where people with different issues of ectodermal dysplasia in Africa, East Africa, and Rwanda locally they have, so that you can create association which can goes with the whole standard worldwide. So we wanted to ask how we can proceed with that, and which standard we can conduct so that we can create association which can give the impact in Africa and Rwanda locally. Thank you very much.
Yeah, so this is a social problem, so it needs to be addressed at the grassroots. Just similar to any other disease, the initiative should come from the population. So you can start from creating awareness in the society and asking the parents and ectodermal dysplasia patients to form their own groups. It can start with a simple WhatsApp group, then it can go with some regular meetings where they can discuss how to face the bullying, how to face the stigma in the society. And once they have a group, they can always form societies and then can always meet the politicians, the policymakers, the healthcare specialists, and ask them how best they can form as a group, get the treatment, preventive therapies, and interventions. So, as I mentioned, the initiative first step should come from the population who are affected. To help them to create or put that first step, as dentists, you all are responsible for this. You need to educate them. So once you educate them, you are empowering them. Then themselves they can take care of majority of these issues. So that first initiative of knowledge that has to come from the younger dentists of Rwanda.
Yes, sure. Thank you. I'm well responded. I may take the floor to other to ask the questions.
Thank you.
Okay, thank you so much, Doctor. My name is Reisite Dosenio. I'm doing dental therapy at University of Rwanda.
Okay.
I'm a third year student. Um, I would like to thank you for good presentation. You got us through ectodermal dysplasia. We really understood as future dental professionals. And now my question comes about the community. As you know, dental therapy is more of preventive in the community.
Yeah.
You know that. Then my question is, what can we tell the families that are raising children with this ectodermal dysplasia, especially in rural resource settings? Thank you.
Yeah. So as parents in the community, first thing they should take care of the children's teeth and overall health. So prevention is something we have to inculcate in the families. Majority of the parents do think that if there are dental problems they will get it treated, but that is not the solution here. Because of the xerostomia, because of the immune deficiency, future problems are very wide. So the parents have to concentrate on the preventive strategies. So as a dental therapy student, you should educate them for the preventive approach rather than a treatment or a curing approach. So you can start with regular dental visits, topical fluoride application, regular use of high fluoridated toothpastes, and frequent sipping of water. So this is something you have to educate any of the parents with ED patients as their children.
Thank you so much. And now I remain with one more question. There is somewhere you mentioned that a dentist is the first one to suspect the condition. So why not a dermatologist?
Yeah, when the child is 1 year old or less than 1 year old, there are hardly any dermatological problems in these patients. So I don't think the parents will even visit a dermatology specialist with the child just because there is no problem or the suspected ED. Usually the suspicion starts from the hairline and also from the absence of teeth. So these are the two early milestones that will give you the red flag. That's the reason possibility of a dentist seeing ED patient is highest compared to any other specialties.
Thank you so much.
Hello.
Very good afternoon.
Good afternoon.
Yes, I have a question on attendees who are applied on Google form, and I would like to read the question they was asked.
Yeah. Can you say your question, please?
You're not seeing the presentation. Screen. Yeah, no, say.
In the meantime, Doc, Suman,
Yeah.
can I ask you my question? In the meantime, they
Yeah.
settle down with the form.
Yep.
You just mentioned about multidisciplinary team. Here I have my own perception is multidisciplinary. It should be interdisciplinary rather than multidisciplinary. And somehow the confusion lies even in the literature regarding multidisciplinary and interdisciplinary. I think interdisciplinary is more synchronized and more patient centric than egocentric. Multidisciplinary, there are multiple disciplines involved, but one doesn't know what the other is going to do. But in interdisciplinary, one person is the coordinator, and then he knows exactly what is the plan, and the plan is always shared by all the members of the team, and then the team acts along with the family, including the family psychologist who will do the counseling part. What do you think about it?
Yeah, I agree with you. There are practical difficulties in handling a multidisciplinary approach, but we have seen how best the multidisciplinary team works in treating oral cancers. So that is a lesson we have to learn. Oral cancers are not handled only by dentists; it is handled by a very good multidisciplinary team. And till date, we have seen how successfully they are able to manage this. So rather than thinking of individual ego, I think it is best always for any team to think about the betterment of the patient and then plan a treatment plan or frequent meetings so that the patient is getting the benefit. And that's how multidisciplinary team should work. So I understand there will be challenges, but it is not an impossible task.
All
All
right.
right, thank you.
Okay, Dr. Sman, are you seeing the slides?
Yeah, I'm seeing your Google form.
All right, all right. There is a person who was asking how long-term psychological impact can be faced by someone with ectodermal dysplasia.
Oh, yes, psychological impact. I have read case reports where patients have attempted suicide. They have become antisocial. They have started avoiding any societal events or family events. They have undergone depression. That is the reason I clearly mentioned that a psychologist is somebody who should be there in the multidisciplinary team, because we know how society treats ugliness, and with the recent use of social media, people do not hesitate just to post these pictures and get some likes. So this is something we need to educate both the patient and the public. That's the reason I think so psychological impact is something very strong in ED patients. The physiological and the anatomical challenges we can easily overcome, but the psychological challenges are very difficult to overcome. That's the reason we need both the patients and the public to go hand in hand.
All right, thank you so much. So, second one is here in Rwanda, but I can or in other country. Is it possible to diagnose ectodermal dysplasia in the early stage of child development?
Yeah, definitely. We are not talking about any genetic diagnosis or any laboratory investigations. We are just asking you to check three things. As I mentioned for the first question, first thing you need to check is there any family history? Is there any person in the family suffering from similar disease, especially if they are siblings or parents? Second one, check the presence or absence of teeth at the age of first year, and check the hairline at the age of first year. So if you see there is deficient hairline and there is no teeth in the mouth by the end of first year, and there is a strong family history, then such patient should be suspected for ED.
All right, all right. Thank you so much. Last more question is a funny question. Do we celebrate the ectodermal dysplasia every year, or is this the first time?
We do not celebrate. This is not a festival. This is a day which we should use to educate the public. If you see my slides, the first slide I have put it in blue background because blue is the color that depicts ectodermal dysplasia. That's the reason I also wore a blue shirt, just to send the message that I support ectodermal dysplasia research. So this is something you can easily practice on every February 20th. You can, as a student, you can always give the message to everybody in the dental school. Okay, on February 20th, wear blue shirt. Thereby, we are increasing the awareness of what is ectodermal dysplasia. So, in short, this is not for one time. This should happen every year. This should happen every year and on February 20th. And it should not limit only to February 20th. Whenever you see a case of ED, you should be able to educate them.
All right, thank you so much.
Can we? I think we have exceeded your time.
Yeah.
We were late by 3 minutes. Just the last question, round up, and we want to thank you for your time. Probably we will have more interactions with you in coming months and days. The only thing is, I wanted to request you if you can be the leader, because I saw the guideline given by America. 2016 is 10 years old guideline.
Yes.
Can we have a revised guideline, especially for continent based, demography based, because every demography has its own challenges.
Yes.
For example, we were struggling for the venue, and at the end, the venue was next to us is our own classroom, and we ended up in our classroom. So we have a better classroom. Next time, you will see the strength of the classroom. Because of the bureaucratic tape, we never got it because it was our mistake. We never applied it on time. We have a very smart classroom which is upstairs, which is probably 10 times bigger than this. But
Okay.
we should have even the audience to honor you in that classroom. So next time, probably we will have 150 audience on
No,
offline listening to you.
no worries.
Thank you very much once
Thank you
again.
very much.
So, any message you have for us?
Yeah, rightly you mentioned that the guideline should come from the local context. It should consider the local problems. That's the reason we have opened this company. If you carefully see our website, our motto is Global South Inclusion and Contextualization Specialists. Our main work is we are concentrating to strengthen these areas of evidence synthesis and guideline development in the global South countries. So I would be happy from my company to say that if at all Rwanda is planning a guideline for ectodermal dysplasia, we would be happy to support you as methodologists. If there is any grant application, we would be happy to part of this and support your initiative.
Definitely, there is a lot of possibility for grant, and I will get back to you on this. Meditronics can help us, the European Union and African Union. I will also knock the door of our president, Paul Kagame.
Yeah. Thanks, Niranjan. Thanks, you all.
Yeah,
Thank you.
thank you very much. Bye bye.
Bye.